Uh, we are here for a guest lecture, and it is my privilege to introduce Dr. Raja Pramanik. He is additional professor in the Department of Medical Oncology at IRCH in AIIMS Delhi. Sir is just like a mentor to me, and I took advices regarding my career and my professional, and I took consider those advices very seriously. Sir is a very renowned academician. He has a good number of publications, and sir is mainly focusing his practice on in gynec cancers, head and neck cancer, GI cancers, and sir has special interest in the hereditary cancers, cancer genomics, and translational research. Sir, as an investigator, sir is doing an ICMR project, which is establishment of a cancer registry of hereditary breast and ovarian cancer and germline DNA repository at AIIMS Delhi. And there is another project by Tata Center of Development of by Chicago, comparison of multi-gene hereditary panel testing, profile in patient with breast cancer, qualifying and non-qualifying the NCCN 2018 criteria for genetic testing, a prospective study in North Indian population. And sir has running many intramural projects. In this today's program, we will be having a guest lecture followed by case-based discussion, and we will like to cover all these areas. Without any delay, I would like to invite Dr. Raja Pramanik for the lecture.
Thank you, Dr. Pramod, for that kind introduction. Respected senior faculty members, dear colleagues and friends, very good afternoon to all of you. I'm extremely delighted to be talking about a topic that is close to my heart before this August gathering. And over the next 40 minutes or so, I'll be talking to you about the roles and responsibilities of the Cancer Genetics Clinic in today's era. So, as a prologue, I would like to introduce that Cancer Genetics Clinic, or a familial cancer clinic, is today an integral part of any comprehensive cancer center. Traditionally, our motto in the familial cancer clinic used to be to identify the at-risk relatives. But now we have a cutting-edge technology in our hand, which is extremely affordable, and that's called next-generation sequencing. And with this has begun the era of precision medicine. So what does it mean? Is that we have to select the right drug for the right patient at the right dose at the right time. So this is the premise of precision medicine. And side by side, we also have something called the era of precision prevention, where by identifying any germline pathogenic variant, we can do cascade testings and risk reduction and prevent cancers from occurring in the first place. This is one of the lowest hanging fruits and highly doable thing in the step for cancer prevention. And this is called high-risk family cancer screening, and this is what we do day in and day out in our family cancer clinics. This is an extremely important step, and this has a potential to change the natural history of the disease in these patients or in these carriers. So I will be speaking to you about hereditary breast ovarian cancers, something about Lynch, Liframini, etc. But mostly my talk will be focused on HPOC. So to understand the potential of this technology and this step of cancer prevention or precision prevention, let's see this story. This is the story of Mrs. Geeta, who is a 46-year-old lady, a homemaker. She has studied up to class 5th. She is diagnosed with cancer breast, invasive ductal carcinoma on the right side, and it's a triple negative breast cancer, 46-year-old lady. Now, this lady knows that she has a family history. Her mother also had CA breast at the age of 40 years, and she expired after 2 years. Her grandmother or Nani also expired from breast cancer. So this is our patient, Geeta. This is her mother. This is her Nani. All had breast cancer. And this history is known to this lady. Also, her Mausi had ovarian cancer at the age of 40 years, and she also expired from that disease. So with this background, she comes to a hospital A. This hospital gives her the treatment, surgery, proper adjuvant chemotherapy, radiation therapy, but no one takes a family history. And let's see what happens 10 years after this event. After 10 years, you see this pedigree has changed. What has happened is that this Geeta, she has died of contralateral breast cancer. She has died of metastatic breast cancer, actually. This is her Mosi. Her daughter also dies of metastatic breast cancer at the age of 42 years. This is Babita ji's daughter, who has developed now carcinoma ovary. This is stage 3C and she is under treatment. So we see this patient has expired. This patient has expired and this patient is currently struggling with her treatment. Suppose had this patient gone to another hospital, hospital D, and met a wise doctor, a dedicated family history is taken in the initial workup. The patient undergoes the same surgery, same adjuvant therapy, chemo, radiation, but this doctor advises her to do a multi-gene germline panel testing. A mutation is detected in BRCA1 and the doctor further advises BRCA test to her daughter, to her Moss's daughter, etc. And then let's see what happens. Geeta is now diagnosed with BRCA1. She has an increased surveillance of the contralateral breast. 1 year later, she is detected with a contralateral breast. It's a small T1 lesion. She undergoes surgery. She also undergoes prophylactic bilateral salpingo-oophorectomy. So Geeta does not develop metastatic breast cancer. She is alive. So Geeta is happy. Now Babita, this is her Moss's daughter. She is 46 years. She also undertakes the BRCA test because her mother died of ovarian cancer. Now she is positive. She undergoes risk reduction salpingo-oophorectomy in the same year. She does not develop CA ovary. She is alive, hale and hearty. This is Sujata, Geeta's daughter. She is 22 years. She tests positive. She marries the next year, completes her family by the age of 30 years, and at 35 years, she chooses risk reduction salpingo-oophorectomy and a yearly MRI for follow-up. She also does not develop CA ovary. So what we see is that we have saved this patient, and we have saved this patient from a sure shot death which would have occurred just by taking family history and doing a test that is a germline genetic test. You can see the power of this test to change the natural history of disease. Now this was hereditary breast ovarian cancer syndrome. Let's see this phenomena going on in a patient with a colon cancer. Here we have something called Lynch syndrome. So Aman is a 30-year-old lawyer. He had some generalized weakness, he underwent checkup and he is found to have iron deficiency anemia. So a male with iron deficiency anemia will go for endoscopies, and there was a sigmoid ulceroproliferative growth. It was a poorly differentiated adenocarcinoma. Now, Aman had a family history of carcinoma colon in his father at a young age of 45 years. His dadi also had colon cancer at 45 years and another second cancer at 60 years. He knew this history. And then the pathologist gave the report that the tumor was deficient MMR on immunohistochemistry. So his doctor advised him an NGS and he was found to have a MSH2 gene pathogenic variant. So this was proven to be Lynch syndrome. And look at the surgery now he undergoes. He undergoes a total proctocolectomy, which otherwise for a sigmoid lesion he would have gone for a resection only. Now he undergoes a total proctocolectomy because he has a MSH2 gene. And then he is on surveillance. Look at the other side. His sister is 40 years old. She is also tested and she is also MSH2 carrier. She undergoes a colonoscopy. A high-grade dysplastic polyp is found out and she also undergoes total proctocolectomy. She has a prophylactic hysterectomy also, and on histopathology is found that she is already harboring a stage 1A endometrial carcinoma and she is on surveillance now. So what we have saved is sure shot cancers in Aman, and we have found very early cancers in his sister, which would have resulted in an advanced cancer later on if detected later on. So this is the power of this technology and application of this technology into clinical practice. So with these two stories, I just wanted to build this, get the ball rolling, and now I'll tell you the details, intricacies of this type of testing. So we all know that cancer is common. Cancer is a common disease. All cancers are genetic, but not all cancers are hereditary. We all know that inside the nucleus there are chromosomes, and inside the chromosomes there are DNA, and if we have spelling mistakes in our DNA, they are known as mutations or variants. Some of these spelling mistakes are silent, some of these are dangerous, they can cause disease. So this is the basic biochemistry we know. Now, most of the cancers, 85% of the overall cancers are sporadic. They occur by chance, by bad luck. 5 to 10% of all cancers are hereditary, that is, they will pass on generations. And in the middle, 5 to 10% have a familial clustering, but we do not have a definite mutation which is underpinning the diagnosis. These are called familial cancers. So what happens in sporadic cancer? We know that each gene has 2 copies, and for a cancer to occur, these tumor suppressor genes, the 2 copies, both of them have to be deleted. That is, we need 2 hits. So for example, a first hit occurs in the A gene, and then after some time, a second hit also occurs in the same gene, in the same cell, in the other allele of the gene A, and when both these are defective, then this patient gets cancer. And for this to strategically happen, it needs a lot of bad luck. But look at this patient in the left side, each cell has A, which has one allele of A that is defective. So all the cells inside his body have one A already defective right from the birth. So this person now needs just only one more hit to develop cancer. And that's why these patients develop cancer early, and one cancer after another cancer repeatedly at early ages. And to top it all, this mutation in A is also present in the germ cells, in the testes or in the ovaries, and therefore these will be passed on to the next generation also. So this is the basic premise of hereditary cancers. And this is what we see if we see in details the pedigree. So on the extreme left side is a sporadic cancer. You see a breast cancer at 67 years and no other family history. This is a sporadic cancer. On the extreme left hand side, you will find breast cancer at 40, then next breast cancer at 43, breast and ovarian cancer at 42. So early age, and each generation has a cancer. There is no generation skipping. And what we see here is the classical pedigree of a hereditary cancer, of a high penetrant hereditary cancer. In the middle, we see a pedigree in which there is a cancer at 55 years, breast cancer, 50 years, and then there is some clustering, but all the generations do not have cancers. So this is what we call a familial cancer, where we cannot pinpoint the exact mutation in a pathogenic gene. So what are the red flags of inherited cancer? So always keep it in your mind that if several members of a family have similar or related cancers, think of hereditary cancers. Young onset cancers, typically less than 50 years, think of hereditary cancers. If there are rare cancers, for example, male breast cancers, think of hereditary cancers. If there are cancers in paired organs, bilateral breast, bilateral kidneys, think of hereditary cancers. If there are multiple primaries in the same person at different points of time, think of hereditary cancers. And if there are other non-malignant features like polyps, hematomas, etc., also think of hereditary cancers. So these are the basic red flags where we as clinicians should suspect hereditary cancers. So how much is the scope of this problem? So if you see, breast cancer, ovarian cancer, colorectal, these are the topmost cancers which have a hereditary predisposition. Others are prostate, pancreas, stomach, and uterine. At least for these cancers, we should be aware that the phenomena of hereditary predisposition exists, and we should be on the look for that in our patients. So let's now focus on HBOC. The first question is, which genes are responsible? So now we know that a number of genes are responsible for hereditary predisposition in breast cancer. We classify them on the basis of their relative risk. If RR, relative risk, is more than 5, we call it a high penetrance gene. That is a high power to produce cancer if this gene is problematic. So, for example, BRCA1, BRCA2. Then there's something called moderate penetrance gene, relative risk 2 to 5. For example, CHEK2, ATM, etc. So they are moderate penetrance gene. And those who have relative risk less than 2, they are called low penetrance genes. And there are a lot number of these genes who individually are not much powerful, but maybe they cooperate with each other or cooperate with the other high risk of moderate penetrance genes. That is the concept right now. These are the hereditary, these are genes which predispose a lady to breast cancer susceptibility. And if you see, these are the ovarian cancer susceptibility genes, and these are the lifetime risks. And we see a great number of overlap. And over the years, we have now learned that some genes have been upgraded, some have been downgraded. For example, PALB2 until last year was a moderate penetrance gene. It is now a high penetrance gene. NBN, RAD50 have now become low penetrance genes. So this keeps on updating. And these are the syndromes which have a hereditary breast cancer as their component. For example, P10 hamartoma syndrome, Cowden syndrome, Lee-Fraumeni syndrome, Peuse-Jeghers syndrome, etc. The next question is, how much is the risk? Okay, if the patient has BRCA1 or BRCA2, how much risk actually is there? So if you see this bar graph, by the age of 70 years, if we see 100 ladies without a mutation, by bad luck or by chance, 12 of them will develop breast cancer. This is the background rate. But if you harbor a BRCA mutation, this is up to 87%, very, very high, up to 8 times higher. For ovarian cancers, up to the lifetime of 70 years, the background rate is less than 1%. But for BRCA1, it's up to 45%. For BRCA2, it's up to 27%. So BRCA2, ovarian cancer is almost half of BRCA1. Now, if a patient has a breast cancer and she has a BRCA1 mutation, what is the likelihood of having another cancer in the contralateral breast? So by the age of 70 years, without mutation, it's 11%. For BRCA1, it's up to 65%. For BRCA2, it's up to 50%. So in men, the risk of breast cancer is less than 1%, but in BRCA2 especially, the risk goes up by 8 times. For prostate cancer, from 14 to 20%, it increases, especially for BRCA2. So to put it in a table, BRCA1, lifetime risk of breast cancer is same for BRCA1 and 2. It's around 55 to 85%, the range. But for ovarian cancer, BRCA2, the risk is half that of BRCA1. Now the next question is, what percentage of our breast cancers do harbor these mutations? So if you look at this problem in literature, you will find diverse results. You will find somewhere 30%, 32, 45. In our experience, retrospective was around 45%. But this is not the true picture. Why? Because these are reports from individual labs. There is strong selection bias. They are enriched samples, retrospective analysis. They have club breast, ovary, unaffected relatives, patients, carriers, everyone. And they represent patients who qualified and who had the funds to do the testing. So this is not the true picture. So with this, we had questions in our mind that what is the true prevalence of germline mutations? If we test all comers, an unselected cohort, that will give us a true picture. So what is our spectrum? Is it the same as they say in the West? Or should everyone be tested? So with this, we went on to do a prospective study at AIIMS. And our objective was to compare the frequency of pathogenic and likely pathogenic mutations in all comers, dividing them into NCCN qualifiers versus non-qualifiers. So this study was done in 2 sites at our All India Institute of Medical Sciences and our second campus, NCI AIIMS Jodhpur. And we had 236 patients. 165 were qualifiers and 71 were non-qualifiers. They did not qualify for the testing according to NCCN guidelines. And if we see, these are the baseline characteristics, median age of 45 years. And if we see, stage 4 was around 22% and triple negative breast cancers were 35%. And now we see that the NCCN qualifiers had a higher percentage of PLP mutations as compared to the NCCN negative ones. But if we club all together, out of these 236, 44 had a pathogenic or a likely pathogenic mutation. This is 18.6%. This is high. This is very high. And if you see the distribution of this pie, 70% of these are in BRCA1 or 2, and 30% are in the non-BRCA genes. So the key messages what we got from this study was that this was the first study to test all consecutive cases of breast cancers in India with a multi-gene panel testing. And we find the PLP frequency is 18.6%. If we do the same test in USA, probably we will find 8.9%. In Nigeria, which also has similar percentage of triple negative breast cancers, it's around 14.5%. So the spectrum of these are exclusively North Indian patients, and 70% of them had BRCA, 30% had non-BRCA. We didn't find any of the Ashkenazi Jewish founder mutations. And we published this in the Annals of Surgical Oncology. And another message that we got is that if we just followed the NCCN criteria, we would have missed 11.3% of the mutations of the patients that we had got here. We also published the VUS that we got and how we managed them. Now, let's see the picture in ovarian cancers. This is our audit from our AIIMS Familial Cancer Clinic, 2018 to 20. We had around 100 patients. 95% of them were old cases, 90% were high-grade serous ovarian cancers. Only 72 could afford the testing, and then 32 out of them had a PLP mutation, that is 44%. We published this in the Journal of Medical and Pediatric Oncology, but this is not the true picture. The true picture is probably this one. This paper is by Dr. Sudeep Gupta et al. And where they tested 239 patients in an unselected fashion from 9 centers in India. 85% of them were new cases. Only 15% had a family history. Only 15%. These were unselected patients. And they did only BRCA1 and 2. And what they find is the likely pathogenic mutation is around 21.4%. This is high. Again, this is very high. So to conclude, to answer the question of what is the frequency, probably for breast cancer, it's around 18.6%, 70%, 30% BRCA, non-BRCA. For ovarian cancer, on the BRCA, you will get 21.4%. And if we test multi-gene, probably it will be 30%. So this is probably close to the truth. If we have more samples, thousands of patients, then that will be the exact data. So now with this, I'll now try to answer certain important clinical questions like why to test, whom to test, when to test, which test, then how to read the test report, how to read the test report, and then what to do after the test. So, and what to do after the test. So, I'll try to answer each questions one by one. The number one question is why to test. So, traditionally, I told you that the motto of the testing was to do cascade testing and offer preventive care to ARR, that is at-risk relatives, so that we ensure proper preventive care to those. But right now, this is not our current motto. Our germline testing is currently informing the treatment decisions. What surgery to do, what chemotherapy to give, what maintenance to give, what PARP inhibitors to give or not to give. These all important decisions are based on these germline testing. If we see, these are the studies in ovarian cancer for first-line maintenance of PARP inhibitors like olaparib and rucaparib. So whom to offer or whom not to offer is the decision is made by the germline testings. For breast cancer, for both adjuvant setting as well as metastatic setting, we can now prescribe PARP inhibitors, and the decision again rests on this germline testing. So it is important therapeutically for the patients, not only for picking up the relatives, but for the patient himself or herself. It's very, very important. Next question is whom to test. If you see the NCCN current guidelines, 2023 version 3, for ovarian cancers, you need to test all epithelial ovarian cancers. For breast cancers, all those who meet the NCCN criteria, and this actually means virtually all patients. Why, I'll tell you later in the next slide. For pancreatic cancer, all patients need to be tested. For prostate cancers, all metastatic patients and all high-risk localized patients need to be tested. So if you see, this is the slide for the NCCN criteria. So any patient who is less than 50 years, go for the testing. Any patient with family history with breast cancer, go for the testing. Any patient with triple negative breast cancer, go for testing. Multiple primaries, go for testing. Lobular cancer, go for testing. And mind it, if there is DCIS, ductal carcinoma in situ, then also you need to go for the germline testing. And now let us see if the patient who had cancer is no more and her first degree relatives want to get tested, you can also do that testing. This is advocated by NCCN. And now let us see this green box. This says that for treatment decisions, if the oncologist is thinking of giving PARP inhibitor in the adjuvant or in the metastatic setting, if you are thinking for that, just go for the testing. So virtually everyone now goes for testing. And this is what in January 2024, the ASCO and Society of Surgical Oncology endorsed. Any lady with a breast cancer less than 65 years of age needs to undergo testing. So after 65 years, then you go for criteria, triple negative, family history, etc. Less than 65, just everyone. So these are the current guidelines. Now the next question again comes is when to test. The answer is as close to the diagnosis in the treatment journey of the patient as possible. So family history should be sought at every visit, and all of us must be having a huge population of patients whom we have treated over the years, but they have not been offered this test. So if you encounter any such patient, please go ahead and prescribe her or him for the test so that they also get the benefit of this testing. So I am fortunate now that with our repeated classes and everything and our teachings, all our senior residents who work up the file, so on the files, the first page of all the patients of breast ovarian cancers at least, you will find a proper pedigree. Though this is heartening to tell. Now the next question is, who should counsel and who should order the test? The conventional model has been, oncologist refers to genetic counselor, then there is a pre-test counseling, then the test happens, then there is a post-test counseling, then he or she is referred back to the treating oncologist. But this is going to be too much because we don't have enough genetic counselors and the criteria of testing are rapidly getting relaxed. So what we need is mainstreaming. What is mainstreaming? Here the oncologist who is treating the patient does the pre-test counseling, orders the test. Only the complex results go to a genetic counselor, or if you don't have a genetic counselor, goes to the MDT. For all the non-complex results and negative results or clear-cut positive results, they get managed by the oncology team because ultimately the risk reduction and surveillance is going to happen by the clinical team. So this applies to all surgical oncologists, all medical oncologists, all radiation oncologists, all gynae surgeons, all breast surgeons. So gear up, we all need to help our patients with this knowledge. And this is a very pragmatic move. This improves access, decreases dropouts, and it's extremely satisfying for the patient as well. And this is what the Indian Society of Medical and Pediatric Oncology in its consensus document now endorses. Now the million dollar question is which test? So mind it, this is a bit tricky. So if we have a family member who has already got the testing and we know that mutation, just go for the single variant testing by Sanger sequencing. This is the standard. But if the mutation is unknown and we are testing the index patient, then the standard of care is a multi-gene panel testing. So which genes, how many genes? The next question arises. So at least include all the high penetrance genes and all the moderate penetrance genes in that panel. So whatever be that panel, 12 gene, 14 gene, 26 gene, 50 gene panel, but at least the high penetrant and moderate penetrant genes must be covered. It can be from blood or saliva, wherever your lab is standardized. Now, it should not be only SNV testing. It should also include a multi-gene ligation, multiplex ligation by probe amplification, that is MLPA. So the final test should be a multi-gene panel test plus MLPA. Because the next generation sequencing has been trained, is a technology that has been trained to detect the spelling mistakes in our DNA. So if the BRCA gene is like a big encyclopedia, the NGS has the capacity, has the power to detect a simple spelling mistake. So it's that powerful. But imagine of a situation when chapter number 4 and 5 of that book have been torn apart. The chapter is not there, chapter 5 is not there. There is no spelling mistake. The NGS cannot pick it up. it's a large deletion or a large duplication, the NGS cannot pick it up. So what we need is a multiplex ligation by probe amplification. Nowadays, with the advancing technologies, the copy number variations can also be picked up by the newer NGS, so we have to be very sure about them. So the best test is multi-gene panel testing plus your digital MLPA. So MLPA should not only be restricted to BRCA1 and 2, it should encompass other genes also. Recently, we are getting a lot of large deletion duplications in the Lynch syndrome genes, even in RAD50, 51C, and T. So this should be incorporated. So what happens when the patient gets, when we get the patient sample? It undergoes a next generation sequencing. Then there is a primary analysis, quality check. Then there is secondary analysis where we get a BAM file and then we get a variant. That is, these are the errors when compared with the standard reference. And then there's a tertiary analysis, whether this mutation that we have found is a pathogenic or a likely pathogenic or not. This is analyzed by tertiary analysis, and then we get a clinical report which goes to the patient and the doctor. So this is what happens. We asked this question to our colleagues in medical oncology, around 50 colleagues, what is your preferred germline testing? So the majority of them answered that multi-gene panel testing is what they order, and if that is negative, they do a reflex digital MLPA. So I'll advise you to do a multi-gene panel with a digital MLPA incorporated, because taking a reflex MLPA again is very annoying for the patient if the patient has to go for the repeat testing. Now let us see this case. This is a 45-year-old triple negative breast cancer. Her mother also had CA ovary. I had a very strong suspicion that this patient will turn out to be BRCA1 positive or BRCA positive. But this is the report on the left hand side, black and white, that I got from a lab. This said not detected, not detected. I repeated this test in a different lab and we found a BRCA1 likely pathogenic mutation. So why was this? Why did the previous lab did not pick this up? It was because this lab was doing only a hotspot testing. That is, only a limited portion of the genes exons were being covered. So the moral of the story is that we have to do a germline testing which covers the BRCA1 and 2 genes, all the exons, and goes inside the introns, at least 10 base pairs padding on both sides of the introns, so that we pick the splice site mutations also. So that should be the test. Let's see this case number 2. This lady was 44 years. She had breast cancer as well as ovarian cancer later on. So very strongly suspicious of HBOC. But with the NGS result was negative. We next did MLPA, and what we found is that a big chunk of the exons, exon 1 to exon 20 of BRCA1 was completely deleted. It was deleted. So this was not picked up by the NGS, and it was picked up by the MLPA only. So MLPA must be added. The moral of the story is please include MLPA. So this is how a mutation is reported by the labs. So on the left hand side, this is how to read a report is BRCA1. The location is exon 15. This is C dot, means complementary DNA position number 4661 to 4662. There is a deletion, del. What has been deleted? AT has been deleted, and then there's a ion insertion of G. So AT deleted and there's G. So this is the change in the DNA. Below that, what you see is a protein, P dot. So this causes the change in the protein. The aspartate at amino acid position number 1554 gets converted into glycine. And this results in the FS, that is frame shift, and then this TER, TER. So 15 amino acids later, the protein is truncated. So a big protein is truncated, it becomes small. So definitely it will be a pathogenic or a defective mutation, defect producing mutation. And this is a heterozygous mutation, autosomal dominant, and the right hand side is what is actionable for the pathologist. This is a pathogenic mutation. Sometimes we get a pathogenic mutation and then a variant of uncertain significance both in the same patient. So this is how a mutation is reported. We have something called HGVS nomenclature. This is the reference genome. This is a C dot point, and then we have the mutation. This is the reference transcript. This is the gene, and this is the coding where there has been a defect. And Then there is a huge amount of work that the bioinformatician does and the labs do to detect, to produce the report whether this is a pathogenic mutation or a benign or a likely pathogenic mutation. So this is how the report comes. This is ACMG, American College of Medical Genetics, class 54321. So we take action only on the 5 and 4. That is definitely pathogenic and likely pathogenic mutation. So how closely is this mutation associated with disease? It doesn't mean the severity of the disease or all that. It just means that how closely it is associated with the disease. And as a clinician, we have to act only on class 5 and class 4, that is definitely pathogenic and likely pathogenic, not on the benign, not on likely benign, and not on the VUS. Now, after we have detected pathogenic mutation, what to do for the patient? So we have to think of these lines. We have to know what are the implications for surgery in this patient. Will there be any change in chemo? Will there be any change in targeted therapy? Then, if a patient has breast cancer, we have to prevent other cancers. That is called secondary prevention. We have to think about the other breast, how to prevent cancer there, either radiological follow-up or risk reduction surgery, and for the ovaries. So what we do for the ovaries in a patient of breast cancer is for BRCA1 at the age of 35 years, we do a risk reduction salpingo-oophorectomy. We cut the tubes and the ovaries so that the patient does not get ovarian cancer in the first place. We do this same thing for BRCA2 at the age of 45 years. So these are guidelines. But the reverse is not true. For advanced ovarian cancer, after the treatment is done, if there is a BRCA mutation, we don't go for risk reduction for the breasts. Why? Because chances of the ovarian cancer coming back and killing the patient is much, much higher than a new breast cancer happening and that killing the patient. So for breast cancer, we go for risk reduction oophorectomy, but for ovarian cancer, we don't go for a risk reduction breast surgery. The next is if the patient doesn't comply with a risk reduction surgery, then intensive surveillance is what is needed. For this, from 25 to 39, we do an annual MRI. For more than 40, we go for annual mammogram and MRI. And then the next step is to identify at-risk relatives, that is by cascade testing. And if we detect a carrier in the family, then we have to think on these lines. The first bubble is, what can we do for primary prevention by surgery, by risk reduction mastectomy or risk reduction oophorectomy? The second is fertility preservation, then intensive surveillance. So for a lady or for a girl who has been diagnosed with BRCA mutation and the patient is a carrier, no personal history of malignancy, what we do is breast cancer awareness from 18 years, then clinical breast examination from 25 years yearly, and then from 25 years, yearly MRI, and from 40 we add an annual mammogram. So this risk reduction salpingo-oophorectomy decreases the risk of ovarian cancer by around 96%. Mastectomy decreases the risk of breast cancer by more than 90%, and oophorectomy also decreases the risk of breast cancer by almost 68%. And this risk reduction salpingo-oophorectomy is not restricted only to BRCA1 and 2. The latest data says we have to consider this for BRIP1, for RAD51C, and for RADS51D. So this was the latest addition in 2023. So this is just an audit of our risk reduction surgeries at our center from 2017 to 22. So these were the list of the mutations in which we thought of risk reduction surgery. So the total number of patients were 50. So surgery for the index cancer was in 19%, along with risk reduction. Only risk reduction salpingo-oophorectomy in 10 patients, and both RRS and definitive surgery in 21 patients. So out of these 50 patients, 31 patients qualified, RRM in 11, RRSO in 5, and RRM plus RRSO in 15 patients. So this is our data. And risk reduction salpingo-oophorectomy, 90% of that was lab, only 10% of that was open. Now we shift gears and to just breezing through the prostate cancer. So metastatic around 12% and localized 5% will be harboring a pathogenic mutation. This is our very small data. This was my intramural project. 29 again consecutive unselected patients. We did the in-house 26 gene panel and we find 10% of prostate cancers were harboring pathogenic or likely pathogenic mutations. So for pancreatic cancers, around 10% of pancreatic cancers are again associated with some form of heritable mutation. Now coming to endometrial cancers, so the main genes are the Lynch syndrome genes, and the Lynch syndrome is called a CEOO gene. C means colon, E means endometrium, O means ovary, and the other O means others. So any tube inside our body, any hollow organ or any tube, be it the esophagus, be it the stomach, be it the urinary bladder, the ureter, all can develop cancer in the Lynch syndrome. So, and we do not have one Lynch syndrome, we have 4 different varieties of Lynch syndromes. The MLH1 Lynch syndrome is very different from the MSH2 Lynch syndrome, very different from MSH6 syndrome, very different from PMS2. PMS2 is the lightest one with very less chances of developing of the cancer. So the pattern of surveillance is very different. So for colon cancers, how do we test? So what we do is do universal MMR, do the IHC test on the biopsy or the surgical specimen for all colon cancers up to the age of 70 years. If there is a loss of expression, go for the NGS multigene panel testing to confirm. But if there is a very strong family history, then we run something called the online PREM algorithm. And if it says its more probability is more than 2.5%, this is a free algorithm. You can just put in the variables, it will calculate probability. We can directly go for NGS panel. So this was for the endometrial cancers. For colon cancers, we have 2 types of syndromes. Polyposis, that is the colon has a number of polyps and then it proceeds to cancer. The second is non-polyposis. So directly it goes on to develop cancer. So FAP, MAP and hematoma syndromes, and the non-polyposis are Lynch syndromes. If we see, non-polyposis colon cancer is around 3% of all colon cancers. So how to test? For non-polyposis, we do again the same approach that we use for endometrium. Universal MMR. All patients, surgical specimen goes to pathologist and they do a MMR IHC just. The simple cheap test, and if there is loss of expression, then go for a germline mutation. If there is a very strong family history, then go for the PREM5 algorithm and go for the NGS directly. But if there is polyposis, it's not the Lynch syndrome. We are thinking of either APC gene or MUT1 gene, then go for the NGS full gene panel. This is the PREM algorithm. It's available free of cost online. We can just put the variables, age, family history of the patient, and it will tell us whether to go for the testing or not. Okay. So these are the tests for Lynch syndromes, how we follow them up. We do a yearly colonoscopy. For uterus, we advise prophylactic hysterectomy after family completion. For ovaries, we do screening, and for stomach, we do a upper GI endoscopy yearly. For FAP, the familial adenomatous polyposis, we do sigmoidoscopy or colonoscopy at least 10 years before the occurrence of cancer in the youngest family member. And for duodenum, we do a side viewing endoscopy. For thyroid, we cervical US ultrasound, and ultrasound for the CT or MRI for the desmoids also. There are many other syndromes for gastric cancer, diffuse hereditary gastric cancer for CDH1, MEN syndromes, then familial paraganglioma syndromes also. So each of them has their list of genes and what to do if any of these genes is detected to be defective. We have NCCN criteria for all that. And the last one is a Lee-Fromini syndrome. It is called SABL, the sarcoma, breast, leukemia, lymphoma, adrenal syndrome. And if we detect a P53 mutation, then we follow the Toronto protocol. This is lifelong surveillance. And for adults, it's mainly a dedicated brain MRI, a dedicated breast MRI yearly, and a fast MRI of the entire whole body. So this is done every yearly. For children, we do a brain MRI and we do an ultrasound abdomen. So this was a brief about how do we do in clinical practice the germline testing and what we do after that. Just imagine the potential of genetic testing for cancer prevention. If we say our population, if we fit that into a football stadium, one gallery will be full of patients who have BRCA mutation, the green gallery, and another full gallery will be full of patients who have Lynch syndrome. So this is the burden which is hiding in our society. We have not picked that up. And this is the potential of this germline testing. So for each patient, if we test positive of any of these mutations and we test the at-risk relatives, these are the star ones are the at-risk relative, and see how many patients are eligible for testing. And if we pick at least 1 or 2 from each of these families, a lot patients can be saved from having cancer in the first place. We can change the natural history. We're not talking of treating cancers, we are talking of not letting the cancer happen in the first place. So with this motto, we had started the familial cancer clinic in AIIMS. We are open there every Saturday. We start at 9 with the pre-test counselings, and after at 12 o'clock we have a MDT, multidisciplinary team meeting with our surgical oncologists and gynecologists who actually do the risk reduction surgeries. And this is our in-house 26 gene panel testing that we are currently doing, and this is one of our reports. And every week on Saturdays, we discuss the complex cases and counsel the patients in our MDT. This is very satisfying for the patient, and we don't jump into the risk reduction surgeries in one go. There are at least 3 sessions of counseling with enough cooling off period before we go for the final risk reduction surgeries. We adapted to culturally appropriate counseling, because generally counseling is a one-to-one affair, but in India, the entire family wants to attend. So we have to ask permission for the patient, and then we can make the entire family sit together for the pre-test counselings. But the post-test, generally, it must be one-to-one counseling. All this data at our clinic is fed to a HIPAA-compliant registry, it's in the red cap format, and we have each patient has a family ID, and each patient has a unique genetic ID. Under one family ID, there can be multiple genetic IDs also. And this is my team. This is my postdoc, Dr. Shweta. Sanchita is my research assistant. Parul is the nurse, and Rahul is the attendant. And I have trained all of them to double up their roles as genetic counselors along with me. So they are all hired under this project, which is ICMR funded project of HBAC registry at AIIMS. And this is the website of our HBOC registry. I request all of you to visit this page, and you will land up with this photograph of a family. We wanted to give a positive vibe to our patients. So this is a professional model family. They are not patients. So just to give a positive vibe to our clinic, we have added this. And in this, we have links to our YouTube channel where we have videos from our faculties giving short videos, short messages of the importance of familial cancer testing. We have awareness messages in all local languages, and we have survivor stories from our patients and patients who have undergone risk reduction surgeries themselves to give in their perspective. We have collated all our research, national research and international research there also. And so finally, with this, my take-home messages is that the cancer genomics is a very powerful cutting-edge tool. Detecting hereditary cancers and identifying high-risk families can actually save lives. They can change the natural history of disease. So please be there for your patients. Ask for a family history whenever you are taking a history. Increased awareness about HBOC and Lynch. And finally, the guidelines are rapidly changing. Every day or every month you will find something new. So please update yourself with the recent most guidelines that will help your patients. These are all my collaborators, and I want to thank them and the funding agencies for their contribution. And finally, I thank all my patients for this. Thank you very much for your patient listening. And I'm happy to take any questions. Yes, Dr. Punya.
Excellent talk, sir. Just one query. How difficult it is for a clinician really to understand that much molecular stuff? You are talking about basically the physician scientist concept. So how difficult it is for us to adopt?
So I don't think it's that difficult. We all have learned biochemistry in our curriculum, and this is more of a compulsion on us to study at least in some depth and understand the molecular intricacies. Participate in CMEs, which are on these topics, because they are very, very vital in decision making right now. So for the benefit of our patients and to practice, this is actually compulsory for us. It is not that difficult, I assure you. This is not that difficult, but of course there is a learning curve for this. But I don't think it's that difficult. You just have to breeze through the guidelines, just go through the guidelines and discuss with the peers. And a lot of other resources are available on the net also. Up to date is a very important, very good resource. NCCN guidelines are very good resources. So, and they are very continuously updated. So that is the best place to go, I think, the NCCN guidelines. And we all study that to take decisions for our patients. So I don't think this is difficult. We should all strive for this.
Thank you, Dr. Pramanik. Very informative talk. I think has benefited our students, the DM students, as well as the PhD and the MD students as well. Just not a question, but a comment at AIIMS Jodhpur, we have a translational genomic group also. But your talk, I think this will motivate other people to join the group. And I think with the help of genomics, now genomics is everywhere. So unless until it is a part of our life, and as you said that gradually when you start using it, you become conversant with all this terminology, and then it is a part of our life of the patient care. So from the lab, we are moving to the bedside, and I think this is a perfect example. That is how the genomics can help the patient in their day-to-day life, and how we can prevent these cancer, which has a high burden of disease later in the life. So thank you for very informative talk. Thank you.
Thank you, sir.
Sir, may I ask a question?
Please.
Sir, in your experience, what have been your challenges in case of pediatric malignancy counseling? That is one question. And secondly, in a second-tier city, how are you going to encourage clinicians to report and register cases in the cancer registry?
Number one, honestly, pediatrics had not been my domain. I have been following mostly the adult cancers. It's because this was the area of unmet need at our institute. So at our institute, pediatric cancer genetics was already covered excellently by Dr. Madhulika Kapra and her team. Dr. Nirja is now there. So we did not have the felt need for pediatric oncology genetics. Retinoblastoma, your neurofibromatosis, and Men's syndromes, many of these were already been taken care of by that group. So honestly, I didn't venture into the retinoblastoma problems, but of course, leave-from-any patients and their siblings who are young, who are kids, they do come to our clinic, and they are under follow-up. There has been challenges. I'll share my experience about leave-from-any. So these babies, we have been following up right from their early childhood with the Toronto protocol. Doing an MRI in them, whole body MRI is difficult. Doing a brain MRI, we have to sedate them, so that's difficult. But the parents have to cooperate. Often we give just tranquilizers to have this MRIs done. Otherwise, the parents of these patients are very compliant for this reason. So most of the challenges are actually for the caregivers than for the kids. That being said, and for this your second question, that second tier cities, how do we convince our colleagues to participate? See, this HBOC registry that what we have started is just an initiation. So even in Delhi, so this is just AIIMS and NCI. So we started with this. So gradually our plan is to increase it into at least pan Delhi. So we are in contact with other centers, even private centers as well as government centers. So whoever, because everyone is now doing the germline testing, everyone is sending germline testing for 2 private labs, etc. And they are also offering at a affordable cost, which the majority of the middle class people can afford, because this is a lifetime one-time test. It's not every time. So many of them are going for testing. The eligible population in the private sector, they are doing more of these testings. So I have been convincing them to enter the patient data into it. Honestly, many of them have agreed. Many of them don't want to share their data, because here the consent of the patient is also important. So to participate. So we have a section in our HBOC registry where we appeal to our patients. So if you have a report, we appeal directly to the patients also. If you want to participate in this cohort, you can just fill up the form and we will contact you. So that's how we have started. And our plan is to incorporate many other centers from Delhi. In second tier cities, I think the way out, what I think is to participate in CMEs, interact with our peer group, and convince them about the idea. Idea of making registry is only that we follow these patients over long term so that we know what is happening in the Indian cohort. What mutations are important here, what are the VUSs here, what are not the VUSs here. So that is the important thing that we will be contributing to the society with this registry, because long-term follow-up is needed. Okay, so the best way what I do is to reach out to my colleagues through CMEs, through programs, and train the next generation from our senior resident group. So every 3 years they will be they grow up, and now they are everywhere inside Delhi and abroad and outside Delhi also. So that's how we have been doing. I am very hopeful in the coming years more people will join hands.
So sorry, I think I missed the initial part, so I don't know whether it has been discussed initially. So sir, if a young patient comes to us and we are suspecting a germline mutation, we got it tested, like some 39-year-old female with TNBC, with some family history of a mother or grandmother. Now, when patient comes with a positive report of BRCA2, besides the patient, many of the times they ask, like, my daughter is 10 years old or 12-year-old. Should I get a BRCA? What is our take on that? Because it has got very much social implications also for the young girl.
Yeah, very good question. So for the cascade testing, it is the age of cascade testing is different for different genes, because we know what is the syndrome for each gene. For BRCA, it's advised only at 18 years. At 18 years, BRCA doesn't produce cancers. If you see the graphs for the cancers, up to the from 18 years, before 18 years, nothing much happens. Then at the age of 35 plus, it just peaks. 35 to 40, there's a steep rise, just like the hemoglobin curve. So it peaks like that. So 18 years is the cutoff. At 18 years, they become adults. They can be counseled. Otherwise, we have to involve the patient's family or the parents for that. For other genes like P53, we know that even children can develop. So for that, there's no age cutoff. Okay. For Lynch syndrome, we turn to the age that is 10 years before the last or the youngest family member who has developed. So for different genes, it's different. For BRCA, it's 18 years. 18 years.
Can I ask
Sir,
a
you
question?
advise genetic testing advice is important, but analysis is very important. Especially you find different lab have different results. So always advising result the testing, and if you have high suspicion, you need to counter check with the lab. Go more deeper and go more testing. Another regarding, ma'am asking the pediatric genetic testing, especially just like in the DMD disease, if girl may be carrier, but we mostly prefer to advise them to test them after 18 years when she is adult, because it has social implication of if he known and he married to person, then they can say it hide her, they hide the report. So mostly it can be tested after the marriage, so it not have any social implication. So that is the genetic testing in the carrier status.
Yeah, so that's okay, that's fine, because that's appropriate to our society also. So we have a detailed discussion with the patient first, and we do not approach the patient's relatives without the consent of the patient. So that is where these are ethical issues. I think Pramod will cover them. So this is very important. We do not directly reach out to the patient's relatives that please come for the testing. It's the patient who has to give this message to his or her family members, because there are different chemistries inside the family. So once they come up, we discuss the issues of marriage, etc., all of these, and we ask them, when would you like to go for that? This is not a compulsion for them, so they have to take their call. We just empower them to take decisions. This is counseling. Counseling is not to push the testing for them. For the patient, we have to sometimes push for the testing because we are going to take decision on that. But for family relatives or carrier testing, we leave it to the patient. We just empower them for decision making. And regarding the lab, we have to choose a lab that is for which you are confident on. So we need not repeat this again and again. But if you have suspicion, you can get it tested. But stick to a lab, to the scientist of whom you can reach out to, you can talk to over phone, who solves your problems. So have connection with that lab and stick to that lab, which has a good internal database. That's what I do. Thank you.
I have a question. I just got curious about the Lynch syndrome patients that you talked about. And you said that, so the curiosity is like the patient presentation and management of whether they have MSH1, MLH1 or MSH2, PMS2. Are they really that different? Because as far as the guideline goes, it just says either you do MSI test or MMR test, and MSI gives only MSI high or MSI stable. Now, whether it's MLH1 mutation or PMS2 mutation, it's still MSI high. So, how do you, and guideline also says that, either you do MSI or you do the IHC, right? So, how does it?
Yeah, I'm glad you asked this question, sir. So this is the difference between the somatic therapeutic decision making and the germline testing, sir. So MSI is a signature. MMR is deficiency of mismatch repair proteins, which we get at the level of proteins. So this is IHC. So MSI high is deficient MMR. This is on the tissue. And if any of these is positive, either MSI by PCR or MMR by IHC is positive or deficient, which means this patient is going to respond to immunotherapy. So it doesn't make a sense which gene is defective, whether it is a somatic mutation or is a Lynch patient causing this MSI high. He or she will respond to immunotherapy. That's the therapeutic decision making. But we have to know the germline, the cause of that. If we know the cause of that, then to test how to test the family members, this becomes important. And for this, we have 4 different types of Lynch syndrome. For example, the PMS2 Lynch syndrome is very little chance of developing of endometrial cancer, very little chance of developing colon cancer as compared to MSH6. MSH2 and MSH6, they are very powerful, sir. And these genes actually work in pairs. So PMS2 is the weakest of these genes. So if you see these guidelines, the NCCN guidelines, they have 1 page for 1 gene. So the frequency of colonoscopy becomes 3 years. The frequency of colonoscopy becomes 1 year in high risk in MSH2, MSH6. So they are very different. The percentage chances of lifetime risk are very different for each of them. So that is for the germline part. But for somatic, if you're thinking of treatment decision, nothing changes. All of them will respond to immunotherapy. That's the take, sir.
I think that's wonderful, and it was a wonderful talk. Just one more question: that patients with, so if you have suspicion on HbOc, now if you go for BRCA1, BRCA2 panel, it comes at a much lower cost, and a large percentage of patients will be BRCA1, BRCA2. STK11 RAD genes, each one of them probably will be less than 1%. So I was wondering, while the guidelines do suggest that multi-gene panel plus MLPA, in the Indian context, would it make sense, it's just a question, that you do it in a stepwise manner? In majority of cases, if they are caught at BRCA level, probably they don't end up paying extra cost for. Just a question.
Yes, sir. Thank you for that question, sir. Number one, the approach today has changed. First, around 20 years ago or 10 years ago even, 2000 to 2010, we used to see the phenotype of the patient. We used to draw big pedigrees, then think of what is the probability, pre-test probability, and then we tested one gene, okay, negative, then go for the next gene. So this was the approach at that time. But now our approach is a combing approach. Because we are seeing that if we are going with the phenotype based discoveries, we are missing patients. A huge number of patients we are missing. So we are going for a combing approach. Just test everyone. Because the implications are so high, now we need a multi-gene panel. Because risk reduction surgeries, I told you, is not only for BRCA1 and 2, it's for RAD51C, 51D, also for BRIP1 also, which are the moderate penetrance gene. Now coming to the second question, so the cost actually does not increase. If we see, if the large scale, the big labs that they are doing, they will do the multi-gene panel at around 10,000 rupees. They do BRCA1 and 2 also 10,000 rupees. The cost, if there's a large or a big high scale lab, if the scalability is high, the cost is not much different. If you do 26 genes, 2 genes or 140 genes, the cost is almost the same, sir. Because the whole genome primers, if you say that nowadays it comes only for 6,000 rupees, sir. So all the labs, what they're doing this all full exome primers, and then they are selectively working on the bioinformatics of those genes. So the cost is not that different. But if you do it at small scale in our labs, the panels, they are costly. Otherwise, for commercial labs, the cost is not much different for 2 gene versus 12 gene versus 26 genes. That's my take.
One question, if you might permit. So this is not so in various tumor boards, this was a going theme that I observed, and I don't know what is your take for especially somatic mutations. Let's say for lung cancer or prostate cancer, which is not because of some germline mutation. I see a lot of arguments, confusion, and debates when more than one pathogenic mutation is involved. So let's say lung cancer, a pathogenic mutation in EGFR, but you also have a co-mutation in PIK3CA. Now for PIK3CA, in breast cancer, alpelisib is approved. For lung cancer, it is not approved. But EGFR, let's say erlotinib is approved. So this is the most common questions that, okay, so if the patient, advanced stage metastatic lung cancer patient with EGFR and PIK3CA, should I also give alpelisib along with? So this is 2 years before I used to hear all these arguments. I want to just generally, if such a patient comes to you, usually what you do?
Yes, sir. These cases are discussed in the molecular tumor boards, and we go with one driver mutation. Generally, there are not more than one driver mutation, so which is phenotypically more relevant. There should be a phenotype-genotype match, and that's the premise of, if you see molecular reports for the somatic mutations, it's not the exactly ACMG guidelines. It's a AMP guidelines. So they will give reports, not likely pathogenic, VUS, like that. They will give it tier 1, 2A, 2B, 3, like that. That is based on just on actionability. So tier 1 means, okay, we have evidence of this mutation, we have a drug matched to this mutation in this particular tumor type. For example, lung and your osimertinib. Okay. But if we have a mutation which is not found in this, but for some other cancer it is approved, like olaparib is approved in ovarian cancer or breast cancer, but the patient we have detected the mutation is a colon cancer. So this is a tier 2B mutation. So like that. So the value of that mutation goes down. It will not not have a good therapeutic effect as the tier level goes higher. So only tier 1 and tier 2A, they are generally considered actionable. So PIK3CA most probably will not be actionable because the driver here is EGFR. And these confusions are usually solved by molecular tumor boards on this.
Thank you.
I think Pramod has a few cases.
We have prepared 4 cases, but after this elaborate discussion, so we will skip that session. And I would like to invite Kuldeep Singh sir and Rakesh Vyas sir to on the desk for felicitation of Dr.
Most of the questions which Pramod had prepared, many of them, I think 80% of them were covered by the audience here. Thank you very much for those lovely questions and the opportunity to answer them. Thank you.
With this, I would like to end the session, and I thank all the audience which is present here, and I special thanks to Dr. Nayan Tada, who has helped me to prepare the pedigree charts of my cases. So very thank to all the everybody who's joined us today.